Okay, I think we will start. Good evening, everyone. Respected Dr. Niranjan sir, members of the Safe Dental Updates, and dear doctors. We welcome you all for our 21st Learn from Our Master series organized by Safe Dental Updates. And it's always a great honor to be here. So firstly, we would like to introduce ourselves. We are Safe Dental Updates, a dental platform in which we believe quality education always ensures predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professionals and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is the best obturation material given by Dr. Niranjan Vatkar sir. To speak a few words about him, Dr. Niranjan Vatkar sir completed his BDS from GDC Mumbai and MDS in Conservative Dentistry and Endodontics in MA Rangunwala Dental College, Pune. He's a key opinion speaker for Endostar, Dentsply Sirona, and India Vikings. His practice purely focused more towards retreatment, microendodontics, direct composite restoration, and metal-free restorations. So without wasting more time, I would like to invite Dr. Niranjan Vatkar sir for today's discussion. Sir, please.
Good evening, everyone. Dr. Shanuf, am I audible?
Yes, sir. The voice and the visuals are fine, sir.
Okay, fine. So let me share my screen first. Okay, so first and foremost, I would really appreciate Dr. Shanuf and his entire team for putting up such a brilliant effort in organizing such kind of webinars. And such kind of webinars should definitely happen quite often, because we need to stay update and abreast with all this recent advancement that are actually happening day by day, and to practically beat each and every field, whether it is endodontics or maybe it is implant, or what other specialty. There's a lot of new inventory that is coming up, a lot of new techniques that are introduced, and it is important that we know this technique, master these techniques, and implement in our day-to-day practice. Okay, so well, friends, when Shanuf actually called me and he asked, so on what exactly would you like to speak of? So I thought of going a bit off track, and I asked him to title my presentation as the best observation material. Because after so many years into practice, we actually come across our own failures of cases, and then we are actually wondering that I'm following the entire protocol, and where things are actually going wrong. This actually takes back me to my undergraduate days, and I still remember my undergraduate posting, like after 4 years of undergraduation, once the internship period was there, so we had this endodontic posting which lasted for almost 2 months. And before I was supposed to join the endodontic posting for 2 months, I was absolutely not well read about endodontics. I didn't know the ABC of endodontics, and I was wondering that how these 2 months are actually going to pass. So at those days, I still remember what I did is that instead of going back to the textbooks, I actually asked my friend who had just finished his posting or was about to finish his endodontic posting, and what materials were used, what files or what inventory did you choose, and in this particular case what exactly should be your protocol. And that is how my 2 months of endodontics passed by. And then eventually I entered post-graduation in 2007, and it was a different game which entered. Practically when I still remember when I entered my post-graduation, uh, I had done root canals only till canine. I had not even touched premolars. And in endodontics, you need to deal with each and every tooth that is there in the patient's mouth, whether it is a third molar, whether it is a mandibular molar which has multiple canals. Oh my God, it was definitely a life-changing experience for me. And that is how we learn. We learn from our own mistakes. And so over a period of time, I know, in this particular case, what goes, and how to deal with complex cases. So friends, here we are today to talk about the best obturation material, and I would give you the complete insight as to what exactly you can implement in your day-to-day practice. Okay. So friends, this endodontic treatment that is there, we can divide it into five major stages which are there. So first and foremost, the most important thing is the access. The access is, I would say, a stepping stone, or the first first, you can say, the first instance where you are dealing with the decayed tooth. So when it comes to access, I speak about this a lot during my webinars, that we need to be as conservative as possible. Just give me a second. Extremely sorry. Okay, so this access which is there, we need to be as conservative as possible. Coming on to the next step is shaping. Again, shaping also involves today, as so today we are dealing with file systems which has to be less tapered in size. Next, the most important, or I would say the rock star in endodontics, is cleaning. So your irrigation with sodium hypochlorite should be should, like you should not compromise on it. Okay, you should definitely clean all the root canals, and you should not compromise on the amount of time that you spend on cleaning. Moving on to the next step is obturation. Whatever cavity has been prepared with your rotary files, and also with the during the access cavity preparation, all of this has to be sealed. Nothing should be left open. And coming on to the last and the most important thing is core. So if the upper four aspects of endodontics has been performed properly, and if you're not doing a good core over it, then it does not make a sense that your root canal is going to last. So today we are here to talk one important aspect of the endodontics, that is obturation. Okay, so well friends, obturation, like I would say, it has always been a base right from our UG days, and obturation is this one step which nobody can say that that I have not learned during my UG days. It is definitely necessary to obturate each and every canal. Now, when it comes to obturation, we are always talking of lateral condensation technique, or lateral condensation with today's bioceramic sealers, or lateral condensation, or our 3D warm Gadapacha obturation, and some other techniques also. Okay, so it includes the squirt technique also, or a single wave of condensation. So all of these techniques are important. Okay, so first and foremost, it is important that I should be obturating the canal. I don't want to leave it open, because if I'm leaving it open, I am inviting a new trouble, which eventually I only have to solve it on my own. So patient is going to pay you for the treatment that you are going to offer, but he is not going to repay you in case if your own treatment goes wrong. Okay, so what do I expect from my obturation material? Well, friends, the most important thing is that it should prevent coronal leakage of microorganism, or the potential nutrients that are supplied to those microorganisms through the dead space of the root canal system. Okay, so whenever we have a patient who comes to our clinic and he has necrotic pulp, and pus is oozing out, or you can see a periapical lesion, practically the pulp which is there inside the canal is dead. Okay, and whatever this decomposed material is there, this is the nutrient to those bacteria. Okay, so whenever we are doing our shaping, whenever we have done our shaping and cleaning of the root canal, we need to fill them up again, because I don't want any ingress of any potential nutrients or bacteria which would enter again into the root canal and cause some reinfection. Then it is important to prevent periodontal or periodical or periodontal fluids which are percolating into the root canals and feeding the microbes. Now the point which I spoke earlier is actually related to the coronal aspect of the root canal. What is again important is the apical third also, because again there are chances that if we don't seal the apical foramen, 100% there is a chance that it may lead to a primary perio and a secondary endo reinfection. Okay. And the most important thing, okay, the third is a third point, that I want to entomb any residual microorganism that has survived the debridement or disinfection stage of the treatment. Okay. So let's take an example that we have a root canal space of a central incisor, and we have shaped this canal, we have cleaned it well, but there is some tiny accessory canal, maybe an apical delta, apical vein, God knows what it is. Okay, but there is some tiny dead space which has still left some vital or viable bacteria behind. Okay, now in case if now the shaping and the cleaning protocol is already done. Okay, now suppose if I don't seal this entry of the of this tiny space, then there is a possibility that these bacteria may get a chance to regrow, because there will be an anaerobic environment for them to multiply and cause some reinfection. So my obturating material which is there, it should entomb, or it should completely seal any kind of orifice which is there inside the root canal space. Okay. Not only that, a few other requirements from my obturating material is that it should seal 100%. There should not be any leaky margin. Either it is a coronal part, middle third, or the apical third. Most important is that it should be inert. Okay, so let's take an example that my obturating material slightly extrudes beyond the apical foramen. So I don't want this material to create some new environment which will eventually reinfect or cause some increase in the concentration of the bacteria. Okay, it is important that it should be antibacterial. Okay, because the main niche of the bacteria is always there in the apical third. We are practically not thinking so much of the coronal third and the middle third of the part, and it should promote healing. Okay, so let's take an example that by mistake, if my obturation material slightly extrudes beyond apical foramen, it should not be a foreign body to the PDL or whatever periapical region is there. Okay, so it should promote healing. So in case if I have a lesion there, it should promote healing and it should not cause any increase in the infection. Okay, so Gadapacha has always been, it has been like time-tested material, and since so many years we are, using Gadapacha for obturating root canals day in, day out. Okay, the main reason why Gadapacha has been, I would say, a game changer when it was first introduced in endodontics is because of its ease of use. Okay, so since it is a rubber and it has the ability to compress, we can literally pack the Gadapacha into whatever canal space is there inside the root canal. And it is literally a skill proof, so in today's era of bioceramic sealer, when we are actually talking of obturating the entire root canal system using one single Gadapacha cone, a single cone technique with bioceramic sealer, it is literally skill proof. I can tell my daughter or my son, you just take this Gadapacha, takes a bioceramic sealer on the hand and just put it inside the canal, chuck it off on the orifice, and your job is done. It is literally that skill proof. Okay, so you don't really require some enormous training that as to how do I obturate the root canal with Gadapacha. If your shaping is fine, the Gadapacha is definitely going to fit into the root canal space. Okay, but there are some issues of this Gadapacha. Okay, so the most important thing is that it does not seal the apical foramen completely. Okay, so let's take an example that you are a follower of a three-dimensional obturation, and when we are heating the Gadapacha and this heat gets transmitted till the apical third, there is still a chance that the heat may not get transmitted 100% till that end point of the apical. Okay, so there is a possibility that my Gadapacha may not get completely adapted to the entire apical foramen. There may be some voids that remain behind, which and these voids are nothing but it is a great anaerobic environment for the bacteria to grow. As you can see in this diagram in front of you, the small square, when it is enlarged, and see, you can clearly see that on the Gadapacha there are literally bacterial colonies that are sticking to it. And what does eventually so eventually over a period of time, when you call the patient back for a follow-up, you are wondering that, I've done my cleaning shaping, right? Everything is gone fine. And the obturation was also great. But why does the patient, why has the patient developed a periapical lesion? And then we are wondering what exactly went wrong. Okay. Second important or second major disadvantage is that if extruded, a lot of biofilm grows. Okay. Now, let me talk here about this biofilm in the apical third. Now, this biofilm is nothing but it is a collagen matrix. So let's take an example that you have a net, okay, plastic net on which a lot of bacteria are sticking to it. So this biofilm which is there, it is not that easy to remove. So just with our sodium hypochlorite irrigation, it is not easy to remove a biofilm from the apical third of the root canal. Okay, so a biofilm is too stubborn to get eliminated from the apical third. Okay. On the contrary, if there are some loose bacteria which are there in the root canal space, they can easily get eliminated by simply doing shaping of the root canal and simply doing irrigation. But when it comes to this biofilm, it is very, very stubborn. Okay. So you cannot practically, or it is not that easy to remove a biofilm from the apical third of the root canal. And on top of that, if I have an extruded gutta percha, which has now gone beyond the apical foramen, and if some amount of biofilm grows over that, my God, then you had it. So, let's imagine this scenario. You have a case where accidentally the gutta percha got extruded. Okay. And now after 6 or 8 months, now the patient has developed a periapical lesion. Patient says, yes, doctor, I have some pain while, biting. Now we go ahead and we initiate the retreatment, okay, of the root canal, and accidentally this gutta percha which has gone beyond the apical third does not get eliminated. Okay, so the gutta percha breaks, like the gutta percha which was there in the main canal, that has been completely removed, but small tiny piece has now remained, and now it is beyond apical third. And so there is only one end to this particular case, and that is surgical endodontics. Okay, so it is important that in case if I'm using gutta percha, my gutta percha should not extrude beyond apical third. In fact, I have an excellent video on this. So actually, I'm a part-time YouTuber also. I make a lot of YouTube videos, so you can go back and see that YouTube video, and it is there on basically apex locator. So there is this great Italian clinician called as Domenico Ricciosi. Okay, so Domenico Ricciosi has done a lot of research on this working length in a root canal. Okay, so what does Domenico Ricciosi say? That the exact first and foremost, it is important that today we are not going to obturate till our radiographic working length. Okay, gone are the days. Please don't obturate at the radiographic working length. We should always be obturating at the working length that I get on my apex locators. Okay, so in case after your obturation, if you see that my obturation looks slightly 0.5 1 millimeter short, please don't get scared. Okay, that is actually the anatomic working length. So it is important that even if I'm obturating with my gutta percha, I am not crossing the anatomical landmark, that is the minor apical foramen, in whatever case it is. Okay, and another major disadvantage of gutta percha is that it has no bactericidal effect. Okay, so like the earlier point only. So if my gutta percha gets extruded, I should have some amount of bactericidal effect, but unfortunately that is definitely not present. So there are few gutta percha which have some calcium hydroxide base, but still they are just not sufficient for us for it to heal any periapical lesion. Sorry. So friends, we need some solution. Okay, we need a solution where whatever root canals that I'm going to obturate, I see that it seals the apical third 100%. It is inert inside the canal. It should be easily available, and it does not require much amount of skill for me to obturate the entire root canal. Okay. So, well, friends, the magic material, what I'm talking of here has been introduced. I've still not come to the magic material, but yes, it has been introduced by Mohammad Turabenajan, who is based in Iran. And the magic material, what I'm talking here, is nothing but mineral trioxide aggregate, that is MTA. Believe me, friends, MTA is the best, or I would say for me, it is like a go-to obturation material for each, whatever case that it comes to me. Okay. And especially cases where you have periapical lesions, obturating with gada parcha is going to invite you maybe trouble at a later date. Okay. So the best part of MTA is that it is hydrophilic. Okay. Unlike gada parcha, let's take an example and compare this property with gada parcha. With gada parcha, what do I need? When I'm coating my gada parcha with my resin sealer, okay, so this resin sealer is nothing but a hydrophobic component. As we all know, composite resins, they do not like water. So when I'm going to obturate a particular canal by coating the gutta percha with my resin sealer, I need to see that the canal should be 100% dry. Okay, and even if I'm using 8 or 10 paper points in a single canal, there is some moistness in the dentine per se. Okay, and there is a possibility that my sealer may not get 100% set. Okay, in that wet environment. So unlike that, MTA is hydrophilic. In fact, MTA needs some amount of moistness for it to set inside the canal. Second important thing is that it is biocompatible. Even if this MTA extrudes beyond apical foramen, there is no adverse effect happening with any of the root canal. Whether it is your non-vital case, whether it is your necrotic case, whether it is a case where pus is literally oozing out from the canal, whatever be the case, it is 100% biocompatible. The best and the most important thing is MTA sustains alkaline pH 12.5 and it remains bactericidal. Friends, so a material, for a material to have an antibacterial effect, it should have this alkaline pH. Okay, so MTA has an alkaline pH of it has a pH which is 12.5, which is very much alkaline. And in fact, in cases where I actually have a periapical lesion, I like to slightly extrude the MTA out of the canal so that it retains that bactericidal effect, and it eliminates all the microorganisms and bacteria which are there inside the canal. It can occlude dentin and tubules. A very important aspect is because let's take an example that if I'm using a gada percha and my resin sealer, and accidentally if some part of the wall, the sealer and the gutta percha has not been adapted, so the dentin tubules are practically open then. And if these dentin tubules have some stubborn bacteria like the Enterococcus faecalis, the E. faecalis is a bacteria which is commonly seen in retreatment cases, then there is a possibility that there may be reinfection at a later date. So this MTA has the ability to occlude dentin tubules, and when it is occluding into the dentin tubules, it is also giving the antibacterial effect due to its alkaline pH. Another best part of MTA is that it promotes osteogenesis, cementogenesis, and pedial reformation. That is what we want. Today we are talking about biomimetic approach in restorative dentistry. So we are talking about layering concepts. We are talking about indirect posterior restoration. So this is like biomimetic endodontics. Whatever has been lost, that was given by nature, all of this is coming back to its original form and function. That is what we want. And antibacterial effect are enhanced in presence of dentine. And what does root canal wall have? It has dentine. So this antibacterial effect actually enhances when you're using MTA. These kind of properties or qualities are definitely not seen with gutta percha. Okay. So coming to the most important thing, that how much to pack. Okay, friends, so now when it comes to MTA, there are many companies which are available. Okay, so the ProRoot MTA from Dentsply is definitely the best. The second best is the MTA from Angelus. Okay, so yeah, it is not easy like gutta percha that I take my GP cone, I coat it with my resin sealer or my bioceramic sealer, I put it inside the canal and my job is done. No. MTA obturation requires some amount of time, it requires some amount of effort, and in case if you are using magnification, it will make your job much easier. Okay, so how much to pack MTA? Okay, now it is important that I should pack minimum apical third at least. Okay, so let's take an example that your working length is 18 millimeters, and if I'm dividing this 18 millimeters into three parts, so at least I need to have an increment of 6 millimeters in that particular root canal. Okay, so 1/3 of my root canal should be obturated with my MTA, that is my apical third. Okay, now why only apical third and why not coronal and middle third? The reason why I'm saying here is because our bacterial niche is all happening in that tiny apical third. So all the circus in endodontics is actually happening in that tiny apical third. Okay, so even if you are solving or you are packing that small apical third, your job will be 100% done. In case if you want to extend that increment and extend it till middle third, coronal third, it's absolutely fine. There is nothing wrong in doing that, but it may take some amount of time. And as we all know, time is money. We need to complete our cases as soon as possible. Today patients do not have time. They want to be they want a doctor who is fast and who will do their treatment in the right and ethical manner. Okay, so friends, speaking about this and giving you a rationale about why MTA is a magic material today. So let's move on to the next aspect of my lecture, that is the ARMA material. Okay, so what all things are needed when we need to pack MTA? Now, friends, MTA is nothing but, you can say, it is nothing but the construction cement. Of course, I can't take Ambuja cement or L&T cement and actually pack it inside the patient's mouth. So we need proper medical cement that is there, which is available in the form of an MTA. Okay, so MTA is available in two forms. Okay, first is in a powder and liquid form. Okay, so this powder which is there, I would say it is universal to all the companies. Coming on to the liquid part. Okay, now there are few companies who are actually supplying glycerin with it. Okay, glycerin or propylene glycol to make the consistency a bit something like a gel form. Okay, so I don't know how many of you have actually mixed MTA, but when we are mixing MTA with normal distilled water or maybe saline or LA also, actually you can use these liquids. MTA can be mixed with LA, saline, or this distilled water also. Okay, but the consistency becomes a bit like a sand, so it is difficult for me to carry the sand and take it into the inside the canal. So there are few manufacturers who are actually supplying the liquid of glycerin or glycol, okay, propylene glycol, which makes the consistency a bit something like a putty, which is easy for me to carry from the instrument, put it inside the canal and pack it inside the canal. Okay, apart from that, MTA is also available in a form of called as a bioceramic putty. Okay, so friends, there are two terms in today's market. We are hearing a lot about bioceramic. Okay, so this term is nothing but materials which are related to tricalcium silicates. Okay, so these are materials which actually promote healing. They induce bone formation, so they give a lot of biomimetic approach to the endodontics. So MTA, bioceramic sealer, these are nothing but one and the same. Okay, so MTA can also be called as a bioceramic material. There is nothing wrong into that. Okay, so coming on to the second form of the MTA that is available, it is also available in a putty form. So to give you an example, the consistency is almost similar to the ready mixed temporary cements that are available, like E-Temp, the Cavit. So the consistency is almost similar to that. But this MTA, which is available in a putty consistency, is a bit expensive as compared to the powder and the liquid form. Okay, so MTA, like I mentioned, the companies that are ProRoot MTA is definitely the best. If expense is not an issue, I would highly recommend. If not, the MTA from Angelus definitely works very well. Okay, coming on to the second most important thing is carriers. Yes, now friends, we still remember our undergraduate days where we were using amalgam in those days, and we were using it for core material or for our normal class 1 or class 2 fillings. So as we all know, with amalgam, I can't make a small ball of it and carry it inside the cavity. It is practically not possible. So I need an amalgam carrier for the same. Now, friends, coming here, I can't use amalgam carrier to pack MTA inside a tiny root canal. Okay, but I can use an amalgam carrier to seal a perforation that is there in the floor of the pulp chamber. Okay, I can definitely use it. But when it comes to obturation of root canals, I want a carrier which will literally go inside the root canal, okay, and deliver the increment at least till my middle third. Okay, at least till that extent, I want to take my MTA increment. So it is important that you invest in the carriers. Now, there are two companies, or I would say there are two systems. Okay, one is the economic system that you're seeing in front of your screen. So many companies in India or many dealers, they are manufacturing this kind of carriers. Now, these kind of carriers I have tried from many companies. Well, friends, the arrow that you're seeing in front of your screen, it is exactly pointing to the weakest point of this carrier. So what exactly these carriers are? So basically there is a cannula and there is a piston that actually goes inside. Now this piston which is there is actually attached to a ring. Okay. Now this ring which is there, this ring and this rod or the piston is actually welded to each other. So it is not a one piece material there. Okay. And over a period of time, as the consistency of the MTA becomes hard and when you're obturating inside the root canal, this junction or this joint which is there, it breaks. Okay, and then there have been instances that it broke to such an extent that the piston literally pierced my finger. Okay, it has been happened so on. Okay, so at that moment I decided that I have to invest in a proper standardized MTA carrier system, and that is nothing but the map system. Okay, friends, map system is a wonderful system, I'm telling you. And if you have the money, you should definitely invest in this map system. Okay, now again, in India, there are two options available with actually this map system is available in three forms. Okay, the first option that is there that is available to you is called as map 1. So as you can see in the front of your screen, this full system that is there, it has 3 carriers. On the contrary, the map 1 which is there, which is an economical version of the map system, has only one carrier that is red in color. Okay, and it will do 95% of your job in your day-to-day endodontics. So whether it is my central incisor, whether it is my premolar, whether it is my maxillary molar, mandibular molar, it will do all the job. Okay, if you want to invest into the complete kit which has the which all the 3 carriers, apart from that it has carriers for your surgical endodontics also, where these carriers are actually in an angulated manner and I can precisely go and deliver the increment in a retrograde manner. Okay, so such kind of carriers are also available. So map system is something which you should definitely, I would highly recommend that you please invest. Okay, at least buy the map 1. Okay, that much minimum you should have. If you want to buy the entire kit, that's perfectly fine. Okay, coming on to the next step, that is pluggers. Yes, so once I have carried the material from with my MTA carrier and I have delivered the increment inside the root canal, maybe it may go till middle third, it may reach till coronal third, it might go till apical third also. I need some pluggers to pack this MTA increment inside the canal. Okay, now coming on to pluggers. Now these are the same pluggers that we are using for our warm gutta percha obturation. Okay, so I don't need some separate pluggers. Well, the most important point here, what I want to emphasize is that when it comes to pluggers, you cannot have just one company pluggers and all the root canals in your day-to-day practice can be so you can't use this one single company pluggers for all your root canal in your day-to-day practice. You need to invest in multiple pluggers from multiple companies. Okay, because the canal diameter, the apical third, etc., all of this can vary from person to person. Okay, so it is important that I want a plugger which are different in diameters also and different in length also. So whenever I'm going to any expo-dent, fam-dent, or these dental exhibitions, I always buy pluggers from different companies. So I have, almost 5 to 6 companies, different pluggers. And believe me, friends, I need all of them. Okay, because I don't know that the canal that I'm obturating may vary in, dimension. It may vary in diameter. It may vary in length. Okay. Coming on to paper points, yes, paper points are again an integral part when you are packing MTA. So so we are coming to actually the video of how to pack MTA. So you'll see in those videos that as soon as I use the plugger, okay, and I pack the MTA inside the canal, the moistness that is there from the dentine actually gets accumulated in that MTA increment, and the increment becomes a bit wet. Okay, so to mop it out, I need my paper points. Okay, and as I am mopping that extra moisture from that MTA increment, that increment is also getting literally packed more in the upper. Okay, so friends, as let me go back. So friends, as you have seen here, apart from this, you don't need any other armamentarium in your day-to-day practice when you're using MTA as the obturation material. Okay, so friends, let's see a small video. Okay, so this is a case of a lower premolar. So I have taken an increment with my MTA carrier. At that time, I didn't have the map system. Okay, so I'm using the economical version of the MTA carrier. So once this MTA increment has been, now in this case, it has gone only till the middle third. So from the middle third, now I'm pushing it, and now it goes inside the root canal till the apical third. Okay, so like I have spoken earlier, it is important that my MTA should seal the apical foramen, and it should seal the entire apical third properly. Okay, so as you can see, that is how my first increment is. Okay, now let's talk about this first increment. Okay, so the first increment goes there, and now I'm taking the second increment and I pack it inside the canal. I hope, Shanuf, everything is going fine.
Yes, sir. The visuals and the audio is fine, sir.
Okay, thank you. And now I'm using paper point here just to remove the extra moisture from that particular increment. Okay, that is how the increment goes. Okay, now here I would like to pause for a moment, and I want to speak about the first increment. Well, friends, whenever we are packing MTA, it is important that my first increment reaches the apical third. Unless and until my first increment has reached the apical third, do not take your second increment. So you need to be doubly sure that my increment reaches till the apical third. Then only you take the next increment and you start packing. Okay. Coming on to this another case. See, this is a case of a mandibular molar where I'm obturating the distal canal. Now here you can see the MTA increment is not even going till the middle third. It is just at the coronal third. So from coronal third, now I need to take this increment till the apical third. Okay. So I have taken sufficient amount of MTA because it is a wide canal in diameter. Okay. So I have taken almost 3 increments. And as you can see, the increment is actually, a bit moist. See, so with the paper point, I'm, blotting it and I'm removing that extra moisture. So as I'm blotting it, I'm also pushing it more inside the canal. Okay. So again, these are the pluggers. So you'll see there are different sizes of pluggers that I'm using. Now the plugger that is there in front of your screen has a diameter which will not take me beyond middle third. So now I've shifted to more thinner pluggers. Okay. And I'm pushing the increment more inside the canal. So again, you can see here, as I'm pushing it, the increment becomes a bit wet. As you can see here, the increment has still not reached the apical third. So you need to take these inter X-rays, inter treatment X-rays to verify whether your increment has gone till the apical third or not. See, now I'm pushing the increment more inside the canal with a more thinner plugger. Okay. See, the entire increment has become, slightly wet. And now I'm just, once all the increment has been, or the increment that was supposed to be placed, once you have confirmed that the increment has been placed, then I'm using paper point to remove whatever moisture is there from the canal. Now, friends, here, let's move on to another important aspect that I want to highlight is that once I have placed the increment and that step has been cleared, what do I do with the remainder of the canal? Okay, so should I be using gada porcha, or if the tooth is destructed a lot, should I be doing a postern core? Well, friends, in case if you are going to do a postern core over the MTA increment, then you have two options. Okay, the first option is that you place cotton pellet, you place temporary cement, send the patient back and call him after 24 hours. Okay, because MTA has a setting time of 24 hours. So in case if you make that mistake where once you have packed the MTA is not set, and now you place etchant which now comes in contact with MTA, the MTA is not going to set. Okay, another important aspect here is, or I would say another material which causes the same issue is chlorhexidine. So in case if you have packed MTA inside the canal and due to some reason, if the MTA comes in contact with chlorhexidine, your MTA is not going to set. Okay, so etchant and chlorhexidine, these are two main ingredients, or you can say materials where your MTA will not set 100%. And if it does not set 100%, it will not turn rock hard. And then if you have a soft material which is there in the apical third, it is not going to seal completely. Okay. So like I mentioned, what do we do with the remainder of the canal? So let's take an example in front of us that we have packed MTA. Okay. And on top of that, if I'm placing etchant, it is not going to set completely. So what do I do in this particular scenario? I use some amount of gada porcha, okay, or whatever the middle third and the coronal third of the remainder canal which is there can be packed with gada porcha. So either so the most preferred choice here is definitely the backfill gun that we use in a 3D obturation. Okay, so in 3D obturation, the gun from which gada porcha flows like like a composite increment, that can be used to pack. This is definitely the best option. If not, you can take gada porcha cones and seal it till whatever length they are going. This is not the right method, but yes, you can definitely do it. Okay. Or else, if you want to do a postern core, then some amount of gada porcha has to be in contact with MTA, so that when I'm doing my postern core and when I'm placing the etchant will now be in contact with the gada porcha and it won't be in contact with MTA. So this is like a small hack that I want to share with you. Like in case if you want to, like you have done the MTA obturation and now I want to finish the postern core in the same appointment, then you can pack some amount of gada porcha above the MTA and then you can start doing your postern core and finish the case in one single appointment. Okay. So like you can see the case here in front of you, so I have packed MTA in the apical third, and above that I am using my backfill gun to place gada porcha over that MTA. So again, whenever we are doing warm obturation, I need my pluggers. Okay, so pluggers are like integral part of endo. So you definitely need them. You need to have them. Okay. And on top of this, now, even if I etch, I spray water, nothing is going to happen to that MTA which is there in the apical third. Okay. Now, this was all about posteriors, So again, when it comes to anterior and when we are obturating the canals with MTA, a major issue that actually comes here is the incisal edge. So today in endodontics, we are talking about a biomimetic approach where we are not cutting the tooth structure unnecessary. Okay, so our access preparations today are as small as possible. Okay, so now what really happens here that when it comes to these central incisor or lateral incisor, on the palatal surface there is this concavity. Okay, or there is this shape which is there. Okay, now this top part, the incisal edge which is there, actually acts like an obstruction for my MTA carrier. So, what my objective is that my MTA carrier should take the increment directly till at least the middle third, or preferably till the apical third, so that my increment is precisely delivered till the apical third. But as you can see here, the MTA is, the incisal edge is obstructing and not letting my carrier go inside the canal. Okay, so what do? Then we have to angulate the MTA carrier and drop the increment till the coronal third or the middle third. Then eventually most of the increment is sticking to the canal, and then we have to take more increment. Now it will really be crude if we trim down this incisal edge, or maybe we are enlarging the access cavity from the parietal aspect. This is a wrong method of doing it. Okay, so let's understand this with a case. So see this case where this was a trauma case where I had to treat both these central incisors. Okay, you can see in one particular case the carrier is literally going beyond the apical foramen. Okay, and in the second case the MTA carrier is obstructing only till the middle third. So how do I deal with this particular scenario? Like I said, I don't want to cut the incisal edge so that I get more amount of convenience with my MTA carrier. No, that is a wrong method of doing it. Okay, so let's see the small video on the same. Okay, so to deal with it, again, you need to drop the MTA till the apical third, and with paper points, I need to push the MTA till the end of the root canal. Okay, so I've dropped some amount of MTA there, and with my paper points now, okay, I'm pushing this increment till the apical third. So again, central incisor has, length of almost 20 or 21 millimeters. So I need to have pluggers also, So again, see the first increment. Unless my first increment has reached the apical third, I'm not going to jump to the second increment. Okay. So please verify that your first increment has gone properly to the apical third. Okay. So see another few cases, where a case of a retreatment where there's a huge lesion, and you can clearly appreciate the follow-up X-ray after 6 months, which is there. The lesion has completely regressed. It is eliminated now, and literally there is a PDL that is also formed on the periphery of the root. This is the power of MTA. So cases where where it is non-vital, okay, and you want to use the you want to obturate that particular case, MTA is the material for that case. Okay, you can use it for vital cases also, but for non-vital, it is definitely the best material. See, there's another case where there was a lesion with a distal canal, and you can see the 2-year follow-up of the same case. See the lesion size that was there pre-operatively due to the leaky core that was happening from the distal aspect, and now see the follow-up at 2 years. The normal PDL is formed, the bone is healthy. It's amazing. In fact, what I would say that you could utilize this technique in your implant dentistry also. So if you have a case where there is a lot of periapical lesion and you want to place implant at a later date, the tooth is grossly destructed, what you can do is you can do a temporary root canal of that particular root piece that is remaining behind, place MTA inside the canal or in the apical third, let it be for some months of time, let native bone regenerate, and then you can go ahead and place implant at a later date. So this is the power of MTA, friends, that I wanted to explain it to you. Definitely there is some learning curve to it. It takes some amount of inventory that you need to buy. MTA is not expensive. Okay, carriers are expensive, pluggers are expensive, but it is that one material which will never turn back to you. Okay, it will always remain, the periapical environment will remain inert. There will be no reinfection at any later date unless you have a leaky core, bad crown. All of these, all of these aspects may not help you in long term. But once everything is sealed properly, MTA is not going to let you down. Well, friends, this brings us to our end of webinar. And I would again like to thank all of you who were staying at the end, till the end of the lecture. Well, Dr. Shanuf, it's all up to you now.
Okay, sir. I think we have few questions for related to this topic.
Okay.
Okay. Let's start with one question here.
Yeah.
Mm, okay. So commercially, which MTA is best? Which do you think MTA is recommended?
See, ProRoute MTA, which is there from Dentsply, is definitely the best MTA that is available. But if not, Angelus is another economical version. And see, MTA, if you actually ask me, it is cheaper than gold also. So one gram of MTA, maybe it is 4,500. That's it. And it lasts for many cases. Believe me, friends. Okay, बहुत चलता है वो, because the amount of increment that you need is very less. Okay, so and we are only packing in the apical third. So practically, maybe the first time buying cost is too high, almost 4 5 thousand, 4 5 grand I'm investing, but it definitely works for long, for many cases. Yes or no?
Okay, sir. So the next question is, can we obturate root canal with only bioceramic sealer like Ceraseal?
No. So bioceramic sealers have to be used with gutta percha. So this bioceramic sealer is always a single cone technique. You don't do warm gutta percha obturation with bioceramic sealers.
Okay, sir. So how to obturate curved molar canal with MTA?
Yes, that is one thing which I am also mastering in today. But there is definitely a specific protocol that now I have learned. So to obturate a curved canal, what you need to do is you take that MTA increment inside the canal till whatever length it goes, and you need to use your rotary file. Okay, you need to use a rotary file in a counterclockwise direction at 150 or 200 speed. Okay, so let's take an example that for a straight canal, if you can obturate it with MTA in 15 minutes, a curved canal obturation with MTA will take you not less than half an hour.
Okay, sir. So the next question, on top of MTA, when you're using a gutta percha obturation, so which sealer do you recommend?
See, Shanup, that's an excellent question. Whoever has asked, when it comes to sealer, we are all moving towards resin dentistry. Okay, so see the amount of resin that is there in today's dentistry. There is resin in a light body, there is resin in a composite, there is resin in a bonding agent, there is resin in a sealers. So many things have resin today. So why do we want to shift to a non-resin material? So if everything is going to be resin, all the aspects or all the materials that we place inside the root canal will be biocompatible, or they will be compatible with each other. So when it comes to so it should always be a resin sealer for sure.
Okay, sir. So what is the setting time of MTA?
Yeah, setting time, see, setting time is 24 hours. Okay, but working time, if you ask me, it should be somewhere around 4 to 5 minutes. So after 4 to 5 minutes, the consistency becomes a bit hard. So let's take an example that you have taken some amount of increment and you mix it on the glass slab with a steel spatula. Okay, please use steel spatula, don't use a plastic spatula. Okay, and so you have taken 3 4 increments, and by the time you have packed these increments, the material that I mixed on the glass slab has now turned a bit hard. So I can, refresh this with the liquid that is there in the MTA, and I can still make the consistency again somewhere on semi-solid or, something like a putty.
How about we using MTA in apical third of root fracture case of immature tooth?
Of immediate, yes, you should be using it. That's I would say the best method to do. So whenever you have a root, but here we are talking about horizontal root fracture which is there in the apical third. Okay, if there has been a root fracture which is there somewhere in the middle third, the prognosis is not that great. So the fracture, if the fracture is more towards the coronal third of the tooth or the root, then the prognosis of that particular case is not going to be good. But if there is a clear-cut horizontal fracture where the two fragments have got separated, you can definitely use MTA in those kind of cases.
Okay, sir. Can treatment be done in case of canal obturated with MTA in past?
That's another excellent question. So in case if you want to retreat a canal that has been obturated with MTA, the best method to remove MTA from canal is ultrasonic. Okay, so here I would again like to request you that if you can go to my YouTube channel, and there's a video on how to remove gadapacha from the canals. Okay, do watch that video. And when it comes to removing MTA from the canals, ultrasonic is the best method. So you just apply some ultrasonic energy to that MTA increment, and it just breaks like sand, and it comes out. Not that difficult.
Okay, sir. So another question is there any particular canal preparation size taper recommended to place the MTA? Is it 2%, 4%, or 6%?
Yeah, for it has to be 4, because see, as such, obturating, there are two aspects to it. So obturating a root canal which is of 6% taper is definitely easier for me to obturate with MTA. But on the contrary, if you see the taper size is too much, there is a possibility that I am removing a lot of pericervical dentin, and the tooth may fracture under masticatory load. On the contrary, if the taper is less, that is 4%, it is definitely difficult for me to pack MT inside the canal. But in the long run, what am I saving? I have saved a lot of dentin, and under masticatory load, the tooth will not fracture. So you need to see that on which side you want to balance your situation. Do you want a larger taper and you want the tooth to fracture at a later date? No, I definitely don't want. In fact, I want smaller tapered canals, and it is a bit challenging for me to pack MTA inside the canal. But in the long run, what do I have? I can definitely give guarantee to the patient that this tooth will not fracture under masticatory load. Okay.
Okay, so the next question is there any particular powder liquid ratio when mixing an MTA?
3:1.
Okay, so let's see if any other questions are there. Some questions are repetitive and some are out of topic also.
That's
sir.
okay.
So,
I have time, Dr. Shanoff. In case if it's all up to you, whatever you feel is best you can.
okay, sir. Okay, can MTA be filled till orifice of a
Yes,
canal?
you can. There is no contract indication, and there is nothing wrong in filling till the coronal third. Okay, it's absolutely fine.
Okay, sir. I think we have reached to the end of the question answer session, sir. I think the last question is, open apex case where apex is bigger than 60 to 70 millimeter, how to obturate the canal?
That's what so the central incisor case that I actually showed it to you, the apical third was beyond the files that are available in endo. So maybe the apical diameter must be some 200, I don't know what it is, 180 or 250, God knows. So in such kind of cases, even if the MT is going beyond apical third, just don't worry what is going to happen to it. But if a gutta percha goes beyond the apical third, then you had it. Then that case is going to turn up into something bad at a later date. So MTA going beyond apex, please don't worry about it. So even in an open apex case where the canals are exuberantly, the apical foramina exuberantly large, nothing is going to happen to it. Okay, so just pack MTA, let it go beyond the apical foramen, but you don't be, don't fear that maybe I should pack less MTA because it goes beyond apex. It may cause some kind of bad response. No, that is not the case.
Okay, sir. How much time can we proceed with middle third obturation with GP?
I actually didn't get this question.
I think what they meant is that once we place the MTA till apical 1/3 and remaining we are trying to obturate with GP, how much is the walking time? Once we place the MTA, then how much time will we need to obturate with GP?
You can do it immediately.
Immediately.
Do it immediately.
Okay.
Yeah. You need to wait.
Okay, so are overlays recommended for such cases?
Are overlays?
Yes, sir.
Yes, actually, in fact, endodontics, I should, of course, I'm speaking to a larger audience here, and even if I, motivate even 5 to 10% here, I would really be happy, So this, so I speak a lot about this conservation of tooth structure, whether it is restorative or whether it is endo. So I would take next, extra 5 minutes of your time here to explain this concept, So let's take an example that a patient walks into your dental office and he has caries, he needs endodontic treatment, okay, but almost more than 50% of the tooth structure is lost due to caries. Now this is not something in my hand, okay. Caries is not, I don't have any control on the amount of caries that is there in the crown part of the tooth structure, okay. But what is there in my hand is I can make a conservative access cavity. I can shape my canals till 4%. There is no need to do brushing action to remove the pericervical dentine. I can give there is no need to do a potion core. And on top of that, if there is so much of destruction already happened due to caries and access cavity enlargement, and on top of that, if I'm cutting the tooth structure 360 degrees, what are we left with? What are we left with यार? मतलब caries की वजह से 50% दांत गया, okay. With access preparation, another 30% is gone. And with crown preparation, you are removing the enamel, boss. Enamel is the strongest part in the human body. And why do I want to cut virgin enamel? Enamel is it is the most important part in today's restorative and adhesive dentistry. More you preserve the enamel, more is going to be the longevity of that particular tooth. So gone are the days where we are doing 360-degree crown prep. So it is important that we come out of this zirconia dentistry. Okay, we want something which is, it has to be biomimetic. Okay, so today overlays, onlays, endo crown, all of these are important aspects that will increase your predictability in endodontics. Okay, please do not do 360-degree crown preps. Okay, please save that enamel. It is definitely going to work in the long run. So 50% of clientele that I treat today are dentists. And many of the dentists, they always say, sir, मेरे को crown नहीं चाहिए. Okay, so they definitely demand that they want an onlays and overlays over the tooth. Okay, so yes, onlays and overlays should be implemented in your day-to-day endodontic practice. Okay, it is not only limited to vital teeth. Okay, you can do them for your endodontically treated teeth also. Yes, Shanu.
Okay, so can we use MTA sealer with GP instead of resin sealer?
Yeah, so this MTA with sealer, actually one company had definitely come out with this particular brand. I don't want to name it here, but it did not actually give proven results. There were a lot of failures eventually happening. See, again the GP component, when it comes together now, there is again an issue that the case may fail again. So try to eliminate that gada porcha component as far as possible, especially in non-vital cases where you see periapical lesion. Your first choice of obturation should always be empty.
Okay, so this is a question, actually, it's a personal question for me, actually.
Yeah.
Because personally, I had done one case where I had placed an MTA. After a few months, the patient, the healing was excellent, but the tooth had stained. There was a discoloration of the tooth. Okay. So is there any any type of MTA which I am supposed to not use, where I could?
So earlier when Dr. Mohammed Torabinajad had introduced MTA, there were two types which are available. There was one gray and there was one white. Okay, so they used to recommend that you use gray for posteriors and white for anterior. But then eventually all the companies have now shifted to white only. Now I don't know what company MTA that was, but if there is a possibility that some amount of gray MTA components was there, it may discolor at a later date. So you please stick to known brands. That is the reason why it is important to stick to known brands. Dentsply, Angelus, these are known brands which are there. So the manufacturing is also standardized and the product that you get is genuine. Okay, there is no some other masala or maybe there is some talcum powder that is put into it. So it is important that you stick to proper brands, and it is not that expensive, Shanuk. I don't know, people when they are buying MTI, they always have this hiccup, nahi, arey, bahut mehenga hai karke. But it is not that expensive and it lasts very, very long because the increment that we need is very less.
Yes, sir.
Yeah.
It is very true, sir.
Yeah.
Okay. I think we had come to the end of this question answer session, sir. And any more other questions are there? We'll definitely try to rectify in any social media platform.
Sure.
Okay, sir. So thank you so much for your knowledge and
you.
expertise when it comes towards
Thank
how to exactly obturate a root canal.
Thank you.
So definitely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. So thanks to all the doctors who had participated for this webinar. I hope all of you will depart this session with positive, confident manner. So again, sir, thank you so much. Thank you so much for lending your time for this wonderful presentation, sir.
Thank you.
Thank you so much, sir. Okay, and thank you all and have a great night.